Welcome back, and thanks for joining us to continue to kick off the conference today with a presentation by Dr. Alvarez Secord, who will update us on what's new in ovarian cancer research and treatment. We'd like to thank Genelux Corporation for making this session possible. Dr. Secord is a professor and director of gynecologic oncology clinical trials at Duke University Medical Center. She's currently serving as president of the Society of Gynecologic Oncology. She has authored more than 200 peer-reviewed articles and has been the recipient of numerous NIH, DoD, and Foundation clinical trial and translational research grants. And we are thrilled and honored that she is joining us today.
Hello, everyone. I am so excited to be here with you. I wish I was there in person. I'm very excited about this meeting, everything that you do, and having a discussion with you today about what's new in GYN oncology. Here are my financial disclosures. And let's talk a little bit about ovarian cancer. This graph on the left highlights the frequency of ovarian cancer around the world. And unfortunately, there's over 300,000 cases globally. This data is from 2020, I believe, and it shows the distribution across all these different continents. And here we are in North America, which is kind of a small piece of that pie demonstrated in red. And you can see the prevalence of this disease globally. Now, in the United States, there's approximately 20,000 cases estimated for 2023, and unfortunately about 13,000 deaths. What we want to do is continue to see that decline in incidence that's shown in the graph on the right at the top light squares. You can see that's been steadily declining since 1992, as well as a decrease in mortality. And we're really excited about that decrease. We don't completely understand why. Some are concerned that maybe that's not a true decrease, but rather these cases being identified as being tubal cancers and rather than ovarian cancers. But nevertheless, we have seen a decline that has been present since the mid-1990s. And in terms of survival, we see an upward trend in survival extending over time from 1975, but continues to be pretty exciting to see this upward trend. So what's new? There's a lot of different things that we can talk about new in ovarian cancer. And for the purpose of this talk, I'll be talking about ovarian cancer, but it's really tubal and peritoneal cancers combined in this group as well. And I broke that down into several different areas, such as screening, prevention, diagnosis, surgery, treatment, and survivorship. So let's talk first a little bit about screening. Here we go. The thought initially was if ovarian cancer is detected early, survival rates may be higher. And unfortunately, the study I'm going to share with you right now, many of you are probably familiar with, is the UKC tox study that was published in Lancet in 2021. And in this study, in the general population, over 200,000 patients were randomly assigned to either multimodal screening, ultrasound screening, or no screening at all. And the follow-up was at 16.3 years. And at the end of that follow-up, 2,055 patients had either fallopian tube or ovarian cancer. And it was evenly distributed across those various groups, approximately 1% in each of those groups I just mentioned. The good news is that stage 1 and 2 disease was more frequently diagnosed in those patients who had multimodal screening, approximately 40% higher compared to the no screening group. Unfortunately, there's no difference in death rates across all of these groups. And so while the increase in early stage cancers, which we thought would lead to improved survival, didn't really occur, we didn't see that survival improvement. And therefore, in the general population, screening is not recommended. Essentially, there's no reliable screening test. And the OCRA did a wonderful job working with SGO in developing a consensus statement. You can find it on the website regarding ovarian cancer screening and symptom awareness consensus statement. Because of these findings, it doesn't mean we're going to stop screening. It doesn't mean we're going to stop talking to patients about symptoms. You know, we used to think if you identify the symptoms soon enough and you catch the cancer earlier as well and change survival outcomes. And that may not be the case either, but it's still important to know about the symptoms of ovarian cancer and seek medical guidance if you do have those symptoms. And we also need to continue to pursue different avenues of screening. So we're certainly looking for that elusive perfect biomarker to detect 100% of all ovarian cancer cases and have a low frequency of what we call false positives, because you don't want to do a lot of surgeries on patients that don't need surgery if they don't have the disease. So one of these tests is called Gallery. This is actually a blood-based early detection study that targets methylation cell-free DNA. And so you basically have blood drawn and you evaluate these biomarkers. And in the initial study called Pathfinder, that was a prospective study, meaning they enrolled patients and studied them going forward. The cancer signal was approximately 1.4%. So you can see pretty low. And it was confirmed in 38%. So of those 1.4% of patients that had some sort of signal concerning for cancer, those patients were later confirmed to have cancer 38% of the time. There's another study building on top of this called Pathfinder 2, and you could just Google Pathfinder 2 and identify sites for enrollment. We do have one open at Duke, and I know there's other centers as well. Another really interesting test is called Pap-Seq, and that's shown in the diagram to the right, where you get a pap smear for the cervix. You can also do a tau brush sample that's up in the uterus, and they also obtained a plasma sample. And the study evaluated how many times you had detection from using either of these methods alone. And if you used both the pap and the plasma test, as shown in purple in that bar graph on the lower right, you had earlier detection, you had increased likelihood of detecting disease compared to either the pap test alone or the plasma test alone. And in this study, what was still somewhat disappointing is that it was still much better for those patients who had more advanced disease, which isn't a surprise. And you weren't able to detect all the cases of patients who had ovarian cancer, but certainly it was higher than the usual testing parameters that we have now. So in that study, there was 83 cancers diagnosed, 16 by pap brush, 19 by plasma, and 17 by both together. Another test that's being conducted is Cancer-Seq, and Cancer-Seq is a blood test only. So more work needs to be done, but certainly there's some new things that are being done in the research area for screening. All right, let's talk a little bit about prevention. Prevention, I think, is an area that we can do a lot more. So what's new for prevention beyond screening? I think it's wonderful. OCRA has a opportunity for free genetic test kit questionnaires for patients. One of the most important things is just understanding your risk. And that means knowing your family history, and that's not readily available for everybody. So one of the things that I wanted to throw out there is just being provocative is, when will it be time for population genetic testing, meaning everyone gets tested? And I do think that will be coming in the future, but when, I'm not sure. It's also important to encourage cascade testing. So if you have a family history of cancer, talk to your doctor about it. It's not just breast or ovarian cancers, but other types of cancers can have genetic predominance as well, like colon cancer, for instance. So tell your doctor about your family history, or if your family history changes. If somebody is diagnosed with one of these mutations that increase the risk of cancer, many of you are probably familiar with BRCA1 or 2, but there's also Lynch syndrome, Cowden syndrome, Lee-Fermini syndrome. There's too many syndromes. Not all of these are associated with ovarian cancer, but if you or your family member has one of them, encourage communication with all your other family members. So if it's something inherited, they can also get tested for the gene. The other area that we're excited about is called opportunistic salpingectomy. And that's where the tubes are removed if childbearing is complete. And let me go back to that 1 second. And if you're undergoing, or you have a friend or family member that's undergoing surgery for any other obstetrical or gynecologic indication, ask them or tell them about asking their doctor about having their tubes removed. And who knows, we may be actually able to extend this to other types of surgeries as well that are not OB or GYN related. In a study that was reported by Hanley, I showed the bar graphs to the right. What was really exciting here is that in that series A, in terms of serous cancers, they expected at least 5 serous cancer cases in the patients in general. And what they found is that there was none of the cases in the group that had opportunistic salpingectomy, and then there was 15 in the control group. And then if you look at all of epithelial ovarian cancer cases, such as the non-serous types, there was less than or equal to 5 in the opportunistic salpingectomy group, and there was 21 in the control group. So it appears that this may make a difference. However, we need to wait for other studies to be resulted and ensure that there's no conflicting information. Let's talk a little bit about removal of the tubes versus removal of the ovaries and tubes. So the tubes really do not have function that we think of anyway after childbearing. And what you see on the figure at the top of the female organs is these little diagrams of what it looks like if you have your tubes removed. So those tubes are those little things at the very top figure. I don't know if you can see my pointer here, that extend off the uterus and to the ovary. And the ovary here is shown in yellow. And this little pink part of the tube here is called the fimbria. So when you remove the ovaries and tubes together, they're completely gone, shown more on that figure toward your left. And if you just remove the tubes, you leave the ovaries, but you want to remove the tubes completely. And here is the uterovarian ligament, and then there's this section here. I think they represent all of this as the ovary. But what you do really want to make sure is that you remove the whole tube and the fimbria portion as well. So there's several important studies that are evaluating this. The one that I know is one of the largest is called SOROC, and this is a non-randomized study where patients get to decide, do they want to have just the tubes removed and not the ovary, or the ovary and tube completely? And they're evaluating whether just removal of the tubes is enough to reduce the risk of ovarian cancer among patients who have a BRCA1 mutation. And so remember SOROC, and if you're interested, I put the title up there as well. It's NRG-CC008. So please reach out to me. There's a lot of centers doing this throughout the country. It's going to be really important to study this, so we know that just removing the tubes is enough, and that the ovaries can remain. And I am not doing this for patients outside of the clinical trial. I think it's really wonderful that we have the opportunity for patients to participate. And again, you're not randomized to one or the other. Patients get to decide. So what about risk-reducing salpingo-oophorectomy? That's where you remove the tubes and ovaries. And it's important to just know your risk. There's a lot of genes that can be associated with breast cancer. I listed some of these here, as well as the Lynch syndrome genes. There's a gene that's associated with non-epithelial ovarian cancers called STK11. This information here and the knowledge of how to treat our patients is growing every year. There's new guidelines. I actually go to nccn.org every time I see a patient, just because I want to make sure there's no updates. And the NCCN panel uses a threshold of 10% to discuss whether or not patients should consider risk-reducing salpingo-oophorectomy. But they also state if there's cases where the life risk estimates are 10 or 5%, then you can also take into consideration family history to determine if preventive surgery is needed. Okay, our next area is diagnosis. You may have heard about ORADS. ORADS is a special ovarian adnexal reporting and data system. For mammograms, I think it's pretty common to see BIRADS on your mammogram reports. ORADS is developed by the same group, and it's specifically developed for the radiologists when they review ultrasound or MRI studies. And the purpose here is to optimize ovarian cancer outcomes and to minimize surgery in patients with these adnexal lesions. ORADS is really complicated. I just put one small part of the scoring system for there on the right, but essentially it helps direct management. So if you have an ORADS score of 4 or 5, for instance, that patient should really be evaluated for a GYN oncologist referral. And the hope is here to streamline the evaluation of the ultrasounds, help us do further research to understand what these findings on the radiologic studies mean, and also help direct patients to the right follow-up and management. Next, let's talk a little bit about surgery. All right, so what's new in surgery? So this special dye was approved by the FDA. And this this article I found called it the glowing tumor. You can see on the right how the dye makes a tumor light up so that the doctors who are doing the surgery are more likely to be able to identify what's disease or not disease. And using this approach, you can be more likely to identify the areas where there's still cancer that needs to be removed. And so 109 patients were in this study. These patients had folate receptor positive ovarian cancer. That's because this special dye targets the folate receptor. And 33% of patients had additional tissue identified at the time of the surgery that was not planned initially for resection and not detected using usual white light and our hands to feel, which is called palpation. The sensitivity of the test was 83%, but the false positive rate was 24.8%. So it means that, when you remove these areas that lit up 83% of the time, it was likely to have cancer there. But the false positive rate means it lit up, you removed it, but there's no cancer there. For the most part, the medication or the dye is really well tolerated. 30% of patients had either nausea, vomiting, or abdominal pain, but they also had surgery. So it's a little hard to tease out what is due to what specifically. But the conclusion of this large study is that paphlocyanine, which I will not say that right, we'll just call it PAPO, may offer an important real-time adjunct to current surgical approaches for ovarian cancer. What we still need to figure out is by identifying this glowing tumor and removing it, are we making a difference in survival outcomes? So I look forward to further evaluation of this agent as well as other agents that are being developed. What's also new in surgery, while it may be chemotherapy related, it does occur during surgery. So I just want to give you an update. There's been a lot of HIPEC interest for a few years based on some of the initial results coming from the Netherlands. And we are waiting for confirmatory trials. There's been some trials that have been negative, and this is a trial that is actually positive. And it was conducted in patients who had first relapse of their ovarian cancer. They responded to chemotherapy and who were thought to have complete surgical resection possible. And so these patients had surgery and were randomized to either HIPEC, that's a hot chemotherapy that's put into the belly, versus no HIPEC. And what they showed on the right in the survival curves is that patients who received HIPEC actually had longer overall survival of 54.3 months versus 45 months. We still want to do better. We're still striving to do better all the time. But this is felt to be a real incremental or real important gain, not just incremental, but substantial. There's still a lot of interest in HIPEC, but there's also some controversy. So the GOG 3068 study, also called HOT, is currently ongoing, and patients on this study have newly diagnosed stage 3 and 4 cancers. They are treated with chemotherapy for 3 cycles, and then they undergo surgery, and they're randomized to either HIPEC with cisplatin, which is a commonly used drug for this, versus no HIPEC. And then they get more chemotherapy followed by a PARP inhibitor. So the study is currently ongoing. I listed the NCT number for you at the bottom if you're interested in learning more. What's new in treatment? Well, this one is really exciting. There's definitely been a lot of progress here moving the needle forward. And I'm going to talk about several pivotal trial results in 2023. Over the course of time, though, I want to just show how much has changed in ovarian cancer. And this timeline demonstrates just how little was available for patients with this disease before 2000. And then after 2014, we have an explosion of approvals, which is still very exciting. There's about 16 approvals. Within these approvals, though, I do have to be a little cautious in how I present them, because while it's 16 approvals, it's really across 3 different drug categories, and now 4 with mirvetuximab, but the predominant ones were bevacizumab across multiple different settings, 3 different PARP inhibitors across different settings, immunotherapy with pembrolizumab and dostarlimab for certain types of cancers. We just talked about the surgical detection methodology, and then mirvetuximab we're going to learn more about. So we'd like to continue to not only develop drugs, but different classes of drugs has really got to be a priority. We also have some retractions here, some of the PARP inhibitors for certain settings, and that's a talk in and of it by itself. But I am very encouraged by the timeline here and by the fact that drug development is going very strong. One of the new drugs, I'm sure you heard about these, is the antibody drug conjugates. This is really cool. And the best way I've ever heard this described was a talk by Dr. Becca Arend, where she described it as a heat-seeking missile opportunity. But essentially, this is an antibody, as you've seen here by the Y-shaped figure. And then there's a linker in yellow, and then the drug in red. And so this drug, with this antibody platform, can be directly delivered into the cancer cell and hopefully have less toxicity. At the end of the day, all of these drugs are going to have some sort of toxicity. I mean, if we get to a point where there's no toxicity, that would be super exciting. But I think for the most part, we have to accept that drugs have some side effects. The good news here is that by delivering this drug specifically to the cancer, we're getting the highest impact of drug delivery to that cancer cell. So mirvetuximab was the first drug in its class to be approved in a gynecologic, in ovarian cancer indication. And I just wanted to highlight also that this is specifically for patients who have a certain biomarker positive disease, and that's folate receptor alpha positive cancer. And it has to be positive based on a certain amount of positivity that you see in the tumor, which is in this classification is high. This was the Mirasol study design. It was an open label design, phase 3 trial where patients who had platinum resistant cancer were randomized to either mirvetuximab or treatment of the physician's choice, either paclitaxel, liposomal doxorubicin, or topotecan. And here are the study results in terms of objective response rate, which is ORR. It's 42% in the mirvetuximab group, which is unheard of. It was so exciting to see the high response rate here compared to chemotherapy, which is typically 16%. And then from these plots, you can see that not only are a lot of patients responding, this is the mirvetuximab on the left in the light orange color, but you can see that the depth of their responses are really high. And that's anything below this dashed line here that represents 30% reduction in tumor. And that some of these patients actually had complete resolution of their cancers. And these are the survival results. So not only did mirvetuximab help control the cancer longer, that's demonstrated by this orange line here. And you can see for some patients, it was really long, sustainable control of their cancer beyond a year, but also it improved overall survival outcomes. And so, again, when I say these numbers, I just want to stress this is an improvement. We have a lot more work to go, but we're still pretty excited to see this because with mirvetuximab, survival outcomes are now over 16 months compared to with chemotherapy, and that's shown by that orange line and this quite striking separation. So one of the things that's frustrating for me right now is I love having mirvetuximab available for my patients, but not everybody's a candidate because you have to have high folate receptor alpha expression. So this other drug called luveltamab also targets folate receptor. And this was conducted in a study where they evaluated 2 different dosing sides. And what we see here is, again, the different blue bars, the light blue and dark blue bar represent the different dosing amounts. And you can see that across the dosing, either whether it's high or low, they had responses. And the swimmer's plot or swimmer's lane on the right shows that some of these responses are really extending far out for several weeks beyond initial treatment. The exciting part here is shown in that lower figure where even when you have the scoring system doesn't show super high expression of folate receptor alpha, even in that group that has 25 to 75%, you see some responses in the 33% range. So it could be that this is a drug that may be available for patients who don't have as high of expression in folate receptor alpha. So we await for further studies to be conducted and see what those readouts are and if this is something available for our patients. Another study that was just reported was a DUO study, and this is a study evaluating paclitaxel carboplatin with an immunotherapy approach with a drug called durvalumab and bevacizumab. And then for the maintenance, it's 3 drugs: durvalumab, bevacizumab, and olaparib. So it's almost like a big cocktail of medications here. And what this study showed is that when you used all of those drugs together, you had better disease control that's shown in that upper red line compared to the 2 other lines. And you had, and that was really most prominent in those patients who had HRD positive cancers. And you also still found that benefit in the HRD negative, but not as high of an extent. But still significantly different findings. What we still have to understand, though, is this benefit mostly driven by the PARP inhibitor compared to the immunotherapy? So we continue to make progress. I think an important aspect here is trying to find out how to identify patients who really will benefit from immune therapy. And some of the data that's coming out of the labs is pretty exciting in terms of how best to identify those patients using biomarkers. This is a drug I wanted to share some information with you. It's from the Destiny Pan-Tumor trial. They evaluated a lot of different cancers in this study, and I'm going to focus really on ovarian cancer. So this is a drug called trastuzumab deruxtecan in patients, and they evaluated them across the HER2 expression noted in these cancers. In ovarian cancer, they had 40 patients in this group, and what I really want to focus on here is the middle figure that shows the objective response rate. And the objective response rate here was 45%. So very exciting results seen here. And 10% of these patients, or 4, had complete resolution of their cancers. And if you evaluate the objective response rate based on the tumor expression of HER2, you see that there's responses across the board, but the highest responses are in those patients that have the 3+ expression at almost 64%. So we look forward to seeing further results here. Any study, though, has side effects. So there are some side effects with this medication. And I think as we continue to do research, we'll identify how better to dose the medication and reduce side effects. I want to share these next slides with you, not really to go through all the trials in detail, but let you know what is going on and the depth of research being done in ovarian cancer right now to improve cure rates. And so this first 4 trials are all immunotherapy studies. They should be reporting out soon, evaluating a variety of drugs that target the immune system and adding them with either a PARP inhibitor or other immunotherapy, for instance, a drug called oregovimab that stimulates the immune system to target the cancer cells that produce CA125 specifically. There's also studies evaluating bevacizumab, which targets the blood vessels, and PARP inhibitors. And then look at all these different studies ongoing right now targeting different kinds of drugs. Now, the first 2 on this list were negative trials. So I just want to, we've had some great positives, but sometimes we don't always find a drug that works in everybody. The Accelerate trial right now is evaluating to see if there's certain patients based on a biomarker that may be more likely to benefit. So I think we'll get more news there. But just really exciting, again, to see across all these different studies what's being done. And then for platinum-sensitive ovarian cancer, there's several studies evaluating mirvetuximab, which we've already talked about in platinum-resistant cancers, that we're very hopeful to have a response in the platinum-sensitive setting as well. All right, I want to just talk about this trial briefly. We mentioned a lot about the serous ovarian cancers and trials for those patients, but there's also some non-serous cancers. These cancers tend to be more rare, and sometimes they can be harder to treat. So cancers like clear cell tumors, for instance. And what this study does is it evaluates the biomarker on the cancer, and then patients are specifically matched to the treatment that goes along with that biomarker. So definitely precision medicine targeting that specific biomarker of interest in patients with clear cell or mucinous or carcinosarcomas. As I mentioned, they're the more rare cancers, and we definitely need to do better in finding drugs that work. So this drug is open, or this trial is open in just a few centers. For us in North Carolina, I'll refer my patients over to Ovarian Cancer Institute. We don't have this trial at Duke, but I think this is a really important study, and I hope that we start to see some results from this trial soon. All right, last, survivorship. This is a strong unmet need. We need to do more. So you may have heard of the Comprehensive Cancer Survivorship Act that was recently introduced to the legislature in 2022 and then reintroduced in June of 2023. I think this is a really important act, and I'm hoping that our bipartisan legislation can get together and work to help patients, because we know that there's a strong need here. Most survivors experience symptoms even years after treatment ends. 74% still have treatment related symptoms 3 to 5 years after diagnosis, 69% even up to 10 years, and then 58% even after 10 years. And that can be the nerve toxicity, pain, fatigue, anxiety, sexual health. There's not enough attention paid, especially for women's sexual health. And we also need to address financial toxicity. So look for this act. See if you can get involved. There's sometimes Hill days or ways that you can reach out to your legislatures and let them know how important this is. So thank you all. I love this quote by Coach K, who's a basketball coach at Duke, is we win when we do it together. And I think that this whole community has shown that we love to do things together, and we're making a huge difference, and there's a lot more work to be done. I wish I could be there with you in person. If you need anything, just reach out.